So, like I said, my name's Andrew Reynolds, and I'm the Hep C Education Manager for Project Inform. And this is sort of a new presentation that I'm doing, so I'm very interested in your feedback for how it goes. It's something that I've been working on, and you guys are my first audience, so I'm looking forward to getting some feedback on that. So we'll do next slide. Well, while we wait, I can just kind of give you all an overview of what this presentation is going to be. I tried to organize it around some kind of key subjects that you might find discussed at CROI. And if not CROI, definitely in some of the conferences that will be coming around hepatitis C. EASL, which is the European Hepatitis, actually liver conference. Then the American Association for the Study of Liver Disease is the liver meeting. That's the American version of EASL, and a few other conferences as well. This won't be a comprehensive overview of hepatitis C, not even close, but I'm open to questions about this. I'm hoping to have about 20 minutes of time for questions if I've done this correctly. We'll have a really brief overview of Hep C epidemiology because I kind of feel like that's an important foundation to put out there. And then I did throw in a couple of brief slides on hepatitis C screening because that's an issue that can be confusing for both patients and providers. And then some key issues in hepatitis C transmission. We may see some of those discussed at CROI. I don't know, but they're definitely important subjects in the current research and literature that folks should know about. And then we'll spend more time going through sort of a detailed overview of the treatments, the ones that are currently FDA available, and then I'll have a list of some of the drugs that are in the pipeline that might actually be discussed at CROI, but just just so you'll recognize them as you look over the presentations and abstracts from the conference. The first slide that you'll see that has actual content on is a slide of the hepatitis C treatment cascade. The HIV cascade is very familiar, and over the last year or two, hepatitis C researchers have used that same model to give us a sense of where we're at in the United States around hepatitis C. And when you see the slide, you'll see that it's an incredibly bleak picture. And it's actually worse than the slide shows. So the first piece is how many people in the United States are living with hepatitis C. And it's about 3.5 million. It's likely much more than that. Some scholars think that if we include populations that have historically been excluded from hepatitis C epidemiology, and here I'm talking about people who inject drugs, homeless folks, people who are in and out of prison. Those are individuals who haven't been covered under Hep C epidemiology. When you include them, the numbers might be as high as 5.2 to 7.1 million, and some people think it might actually be even higher than that. But for the purposes of the cascade, it's 3.5 million. We've diagnosed approximately half of them. So about 50% of people with hepatitis C in the United States don't know their status. And then as you look down the cascade in terms of access to medical care, people who have stayed in medical care, people who have been given treatment, and people who have been cured, the numbers get lower and lower. And the last two bars on the graph kind of illustrate where we're at in terms of treating and curing people for hepatitis C. And of the 3.5 million people who have been officially diagnosed with Hep C, or who are living with Hep C, 16% have been prescribed treatment, and 9% have been cured. So we have a long, long way to go. The good news is the treatments are now better than they've ever been before. And so I would suspect that we probably have more than 9% of people cured with hepatitis C based on the advancements we've had since the end of 2013. But the problem with that is we still have some significant access barriers for people mainly because of the cost of these drugs. I'm not going to talk too much about that today, but if there are questions, I'll obviously get into that. When we think HIV and hepatitis C co-infection, which is going to be a topic that will likely get covered at CROI quite a bit, about 25% of people living with HIV, and we can move on to the next slide and then the next slide. So here's co-infection. About 25% of people with HIV are also living with hepatitis C. We'll talk about Hep C treatments for people who are co-infected. For people who are living with HIV who inject drugs, the co-infection rate is really, really high. 80%, in some cases even higher, dependent upon like in larger cities, some studies have found it, 90–95%. And then an issue that is probably, it's still poorly understood, and it's not studied as well as we would like it to be, but there's enough research out of places like throughout Europe, Australia, and to a lesser extent we've had some stuff done here in the United States. But people living with HIV appear to be at much higher risk of sexual transmission of Hep C than the general population. For reasons that aren't entirely understood. I'll talk about it a little bit later. But there are a lot of individuals who have never injected drugs, who are living with HIV, who are getting diagnosed with Hep C. And I think it's fair to say that the consensus is HIV-infected folks are at greater risk than Hep C, are at greater risk for sexual transmission of Hep C. And screening for Hep C should be a routine practice for folks living with HIV. Next slide. You may see some data on sort of the suffering that comes from hepatitis C, the morbidity and the mortality. There's a lot of really good research out there, and it's really an emerging field. Patient-related outcomes is sort of the piece there. Historically we've said Hep C was a disease of the liver, and I think we kind of screwed up with that. That's what we thought at the time. But when you talk with folks who have been living with hepatitis C and have then been cured, and then if you talk with the researchers who are looking at sort of the quality of life measures of people while they have hepatitis C versus what it's like for them after they've been cured, I think we should move to the statement that hepatitis C is a systemic disease. And it makes sense when you consider that the liver has over 500 bodily functions and is responsible, for so many different things, from producing energy to helping digest food, monitoring sugars and fats and so on and so forth. So if the liver is under stress and under siege from this virus, it would make sense that people would experience, symptoms from the top of their head to the tip of their toes, inside and out. We've always underreported how bad hepatitis C was. Again, we have very poor epidemiology, but when the CDC has done some detailed analysis, and this data comes from a study called CHECK, the CHECK study, where they look at medical records and they really drill down to see what's going on with people living with viral hepatitis. Hep C probably accounts for at least 80,000 deaths per year. I think the official numbers are something like 15 to 17,000, but when Reena Mahajan, the source for this piece, looked at it, she found that it's probably higher, as high as 80,000. People with HCV do die at a much faster rate than the general population, and they actually die more frequently than people with hepatitis, with HIV. And hepatitis C is the leading cause of non-AIDS deaths in people living with HIV as well. It shortens the lifespan by 15 years. It's the leading cause of liver cancer in the United States. It's the leading cause of liver transplants in the United States. So it's a significant personal and public health problem. Next slide. So I'll be real fast, because I want to focus on the treatment, and since we got a little bit of a late start. So for Hep C screening, the things to kind of think about are, you sort of have two phases for Hep C. acute phase and then the chronic phase. And the acute phase is important because in the first 6 months of infection, approximately 20 to 25% of people will clear the virus naturally. We don't know why. We wish we knew why, because maybe we could reproduce it. But this happens in about 1 in 4. These folks will always test antibody positive, but they don't have active virus in their body doing damage to their liver. If somebody tests positive for Hep C and then they have a viral load 6 months out from that first positive antibody test, then they're chronically infected, and they'll have the virus for the rest of their life until they've been treated and cured. So that's the difference between acute and chronic. So the next slide kind of shows what results mean for people. So if a person tests antibody positive and then they're viral load negative, the person was infected at some point, we don't know when, but their body was able to get rid of the virus, either through the spontaneous clearance or from the cure. An important counseling note for these folks is they can get reinfected. Whereas hepatitis A and hepatitis B, if I get it, I'll never get it again. Hep C, you can get reinfected, and reinfection is actually a significant problem, both for people living with HIV and for people who inject drugs, get cured, and then maybe start to share equipment again. It's not as big of a problem as a lot of folks highlight, particularly insurance companies who don't want to treat drug users because they're like, well, why treat somebody when they're just going to get it again? But it's enough of an issue that as counselors, as health educators, we should put that out there and let folks know that once you get cured, do all the things you need to do to stay Hep C negative. Don't share equipment. Talk to your partners, your sexual partners about hepatitis C and so on and so forth. And that's where those counseling messages on modes of transmission and prevention come about. Next slide. So if somebody tests antibody positive and then they are viral load positive, dependent upon when that risk was, like if it happened within the last 3 to 6 months, you might want to do a follow-up RNA test just to make sure that they're not one of those folks who are going to clear the virus. But if it's somebody who's like, oh yeah, you know what, I injected drugs 10 years ago, I haven't used in a while, they're antibody positive, viral load positive, then they're chronically infected with Hep C. And then these are the folks who should get connected to primary care and do the things that need to be done to live healthy with hepatitis C, and then prevent the transmission to others. Next slide. The significant burden of hepatitis C falls on people who inject drugs. The prevalence rate, the overall positivity rate is between 30 and 70%. As I said before, in some cases it's even higher. Incidence, which is new infections, you know, it's tricky. Overall, 16 to 42%. Some people think it might even be higher amongst people who inject drugs, and in certain areas it certainly is. We're starting to see significant outbreaks of infection amongst youth who started with prescription opiates and then graduated into injecting drugs. And they, you know, they're individuals who haven't necessarily been identified as at risk for Hep C when they're taking prescription pills, and then when they, you know, graduate into injection, they don't really know all the harm reduction, risk reduction techniques that are out there, and so sharing of syringes and injecting equipment becomes fairly common, and you see high rates of Hep C as a result. Holly Hagen, who's this great Hep C researcher out of New York, kind of shows the longer a person injects, the greater the likelihood of chronic Hep C. And you know, she, you know, for people who've injected 10 years or more, the rates are really, really quite high in some cases. Overall, around the United States, and this is probably a low number, but about 56% of folks who have Hep C got it through sharing of injection drug use, either syringes or equipment, and we'll talk about the virulence of Hep C, I think, in the next slide. People who inject drugs make up the bulk of folks who are co-infected. And then because of the United States' approach to drug use in this country, predominantly through the war on drugs and criminalizing drug users, jails and prisons become key sites for people with hepatitis C. You know, between 30 and 45% of folks living with Hep C pass through either a jail, you know, for as short as a day, for up to a year, or are in prison each year. And so screening programs in jails and prisons would be a significant public health intervention to reduce Hep C in the United States. Next slide. So these are all the various points of injecting equipment that could become infected, contaminated with hepatitis C. All the little red areas are blood. Hep C is a blood-to-blood infection. And so if blood gets on any of these things and that has Hep C in it, and then that blood gets inside of you, boom, there's the risk. Next slide. So real quick, this is always a real interesting point, and if there are questions at the end, we can talk more about it. But Hep C is super tough, and you know, this is a message that we got to get out to folks, and it's really relatively recent, as you can see from the dates. It can survive in a syringe for up to 63 days. So Hep C can be in there for, you know, 2+ months. This next bullet, it might actually be different now. We know it's 16 days in the community. Julian Dorbicher, a researcher out of Germany, did some really elegant research to find that. But there's a guy, actually the guy above, Eliza Paintsill out of Yale, who recently found that Hep C could live on surfaces in medical settings for up to 6 weeks. Now we don't know what that means in community settings. There's a lot more blood and that type of thing in medical settings, so it could just be that that's relatively unique to that particular setting. But it'll be interesting to see. I mean, this is one of those points of research in hepatitis C that every time we look at it, it seems to change. You know, it used to be Hep C could live for 2 days, then 4 days, then now 16 days. Maybe it's 6 weeks. So keep your eyes open for that if there's any research at Croy on that. I doubt it, but there might be. Hep C can survive in water for long stretches of time, up to 3 weeks. And then what's important here is even if somebody uses like a plastic or aluminum can to hold water, and they're like, oh no, I got some blood in there, I got Hep C, I'm going to dump that bad water out, I'm going to rinse out the bottle and the can, and I'm going to put fresh water in there. That fresh water gets reinfected because the hepatitis C infected blood kind of absorbs in the pores of the plastic and the aluminum cans. This won't happen in glass, so encourage people to use glass bottles to store their rinse water is a way to reduce the risk of Hep C transmission, as long as that water, you know, is fresh and not used. Hep C has been shown to survive in cotton filters for 24 hours if exposed openly to air, 48 hours if it's wrapped in foil. And, you know, just like Hep C can live on surfaces, it lives under the surfaces of cotton, cookers, water, filters, even alcohol wipes. So, you know, folks shouldn't use an alcohol wipe after injecting anyway. They should, you know, kind of people think that that's a good thing to do because it'll kill bacteria, but it actually encourages bleeding. And then if somebody shares that wipe on their arm, boom, Hep C transmission may occur. Next slide. Another piece that I don't think gets enough attention, we haven't done enough research on it, we should be doing more of it, is people who don't inject drugs. There haven't been that many studies, but every time there's been a study, the rates of Hep C have been higher in this population than the general population. And so, you know, I think folks who snort drugs and potentially share straws or share crack or crystal meth or cocaine pipes, hell, even smoke heroin pipes, if lips are bleeding and there's blood-to-blood contact, there's risk for Hep C transmission. And so, as I say in that first bullet, you know, this meta-analysis that looked at 28 studies found rates anywhere from a little over 2% to a little over 35%. Now, there's problems with some of this research. I mean, people might have injected drugs in the past and they're no longer injecting, and now they just smoke. So maybe they got Hep C from the injecting. But it's still enough of a positivity rate that if I'm a counselor and somebody comes in and says, oh, no, I don't inject drugs, but I smoke crack, I'm going to offer that person a hepatitis C test. And then, I gave an example from San Francisco where 17% of samples studied in folks who did not claim to not inject drugs had Hep C. The researchers admit there might have been undisclosed injection drug use behavior, other risk factors. They couldn't pinpoint the risk factor. But again, 17% of non-injection drug users with Hep C, I'm going to offer them a test. And then there isn't a whole lot in terms of interventions to prevent Hep C in this group. We have in many places syringe exchange, which can mitigate against Hep C infection. There aren't crack pipe exchanges except Vancouver. A couple of other cities in Canada actually have done some crack pipe distribution programs. We have a really small one here in San Francisco. But once they started to introduce the crack pipes, new infections of Hep C amongst this population went down over time. Okay, next slide. So sexual transmission of hepatitis C is a really, really important and poorly understood subject amongst people, patients, clients, whatever we want to call them, and even amongst providers. So a brief blurb on that. Overall, sexual transmission is a really sort of low-risk form of transmission in the big picture, especially amongst folks who are HIV negative. This one bullet here, there was a meta-analysis that, I forget the number of studies, but it collected a variety of studies and found that over 9,000 person years, within the study, and an estimated 750,000 vaginal or anal sex encounters, maybe with condoms, maybe without. They weren't able to tease that out. There was not sexual transmission. It happens, on a case-by-case basis, but on a population level, it's so low, we can't really give a percentage. This last bullet I may be changing soon because it is true that prior studies haven't found a lot of sexual transmission of Hep C amongst HIV-negative gay men. But recently there have been a couple of reports published and presented, so peer-reviewed, mainly out of London, that have seen some higher rates of Hep C amongst HIV-negative gay men than previously thought. And the idea might be maybe we're not finding it because we're not testing it enough. It's not a recommended risk factor for screening for Hep C. So if we're not looking for it, we're not going to find it. Perhaps if we started routinely screening for hepatitis C, we would find more of it. Next slide. So as I mentioned at the beginning, HIV is definitely a syndemic factor for hepatitis C. And I'm not going to get too deep into the numbers here, but as you can see, rates of Hep C have increased in HIV-infected gay men who don't inject drugs, whereas Hep C has decreased in people who do inject drugs because of the services that we're able to provide. And these patterns are all over Europe, Australia. There's a couple of small ones in Canada, and then very few in the United States, but when they have looked at it in the United States, they found it. Next slide. And then these are the risk factors that might facilitate sexual transmission of Hep C. Multiple partners, serosorting. So if I'm HIV positive and I don't want to transmit HIV to somebody else, I'm only going to hook up with other HIV positive folks. We don't have to worry about HIV, so we won't wear condoms, and places us at greater risk for STDs and potentially hepatitis C, particularly if there's blood present during sex. I mean, that's the thing. If there's tearing in the anal cavity and there's blood. If there's ulcerative STD like herpes, primary syphilis, and that creates the blood-to-blood contact, that's where the risk lies. They've looked at hepatitis C in sexual fluids, semen, vaginal fluids, and it's been, some studies will find it, other studies won't find it. There's no sort of rhyme or reason to it. But in the studies that have looked at blood during sex, that's where the risk seems to lie. Next slide. And then again, mentioning that reinfection is a significant risk for both people who inject drugs and HIV-positive gay men. So making sure that folks are aware that Hep C reinfection can happen, and that after they've been cured, they'll always test antibody positive, but they won't have virus unless they get reinfected. And as a screening measure, folks who have been cured should either get routine viral loads once a year, once every 6 months. There's no clear guidelines on that. And then in some cases you can monitor liver function tests, but I still say go for the viral load. It's better to be safe than sorry. Next slide. So Hep C today, it couldn't be more exciting. I mean, the treatments are coming out. A couple of new treatments each year. We're going to see that trend continue probably for the next 5+ years. There's things in the pipeline that are looking really, really excited. And this is kind of what it looks like. The interferon stage up to 1998 was miserable. You had to inject yourself 3 times a week, and it cured folks a whopping 10%. It wasn't used very much. Then Ribavirin came on the scene, and you took 2 pills per day and 3 shots a week for 48 weeks, and the cure rates got a little bit better. A few folks got treatment during this time, but it still wasn't widely done. And then you started to see pegylated interferon, which you only had to give yourself an injection once per week. You had to do it for a year, and overall the cure rates were 50%. Better for some genotypes, worse for others. It's worth pointing out that interferon is a completely miserable drug to take. It makes you feel like you have interferon is sort of like your body's natural antiviral. So when you have the flu, you feel like crap. Your joint aches, the fever, the headaches, all that stuff. That's your body making interferon. Pegylated interferon was just a lot more of that injected into you at once. And so folks felt awful for pretty much the whole time that you're on it. It's not like, the side effects don't get better over time. I mean, folks kind of would suffer through it for the year. And then in 2011, things started to change. We had the first generation protease inhibitors come out, but folks still had to take ribavirin and interferon. The side effects were really strong. A lot of folks still couldn't take it. And so again, even though we had this up to 75% cure rates for certain genotypes, it wasn't widely used by a lot of folks, or it would get started by folks. The side effects would be so bad, they'd have to stop. Next slide. Now, I know we're in the interferon-free era. And there are lots of treatment options, and none of them include interferon. So the opportunities for people to get cured are, it blows me away. I actually do a couple of Hep C support groups, and there's this new kind of bittersweet thing that happens in my groups. People leave because they've been cured. It's such a different thing. I mean, folks would be in my groups forever because they wouldn't be on treatment, or the treatment would fail. And anyway, it's a great time. If we can get these pills in people's bodies, we can wipe out this virus. I joke, if we do it right, I'm out of work in 10 to 15 years, and I'm happily out of work at that. When folks are making treatment decisions, the main things they need to know are their genotype. In the United States, it's really 1 through 4 are the ones to think about. You know, there's 6. Some people think there could be as many as 11 around the globe, but we're not going to worry about that. Genotype impacts the treatments that you're going to take, and it impacts the duration. Certain genotypes can be treated for 12 weeks, some might need 24, and so forth. For one drug only, Harvoni, which is made by Gilead, viral load is important because it impacts treatment duration. If your viral load is a little on the lower side, you might be able to do the treatment in as little as 8 weeks. Everybody else, it would be about 12 weeks. And then levels of cirrhosis is also important. The great news about these drugs is even in folks who have cirrhosis, they appear to be remarkably successful. You just might have to take them for a little bit longer. And Ribavirin is still used, and it'll be particularly used for folks with cirrhosis. Next slide. We can skip the next slide. So here's just a list of FDA-approved or drugs that are going to be in the pipeline. You'll probably see a lot of these discussed at CROI. I'm not going to get into too many detail, but it just gives you a nice snapshot. Look at where we're at. This is incredible. You know, 5 years ago we had Interferon and Ribavirin, and now we have more drugs with names that I can't pronounce than I ever could have hoped for. And so it's a really, really exciting time. Next slide. And here's what we have now. Sofosbuvir and Ribavirin, the brand name is Sovaldi. Sofosbuvir and Cimeprevir, the brand name is Sovaldi and Olesio. Sofosbuvir and Ledipasvir, Harvoni. And then the most recent approved regimen, Vicarapac, and then those are names that, you know, good luck pronouncing. Embatasvir, Dasabuvir, and Peritpravir with a ritonavir boost, that HIV medicine. It's used to kind of boost it up a little bit. Next slide. These drugs are no longer used. Interferon is out. There might be a few people still on it from an earlier regimen, but I don't think there's any new prescriptions for interferon being written today. Telaprevir, which was one of the first generation protease inhibitors, it's gone. It's no longer sold in the United States. Might be available in other parts of the world, but again, it was a pretty rough drug, and a lot of people can't take it. It was only for genotype 1 as well. And then most recently, last week or the week before, Merck, which makes Boceprevir, the brand name is Victrellis, they've announced that they're going to discontinue its production in the United States. They're going to keep it available if anybody happens to still be on it. I doubt very much that anybody is, but it's better to be safe than sorry. And even Merck said, don't put anybody on Victrellis going forward. There's better drugs out there. Next slide. So the next group of slides is treatments that are available for folks with various genotypes, treatment experience, and liver health. And I will go through them pretty quickly, keep them and study them. You know, it's not like we're going to memorize all this stuff in one sitting anyway, but it gives a really nice picture of where we're at. So genotype 1, which used to be the most difficult hepatitis C genotype to treat, now has a lot of different options. And for somebody who is treatment naive, does not have cirrhosis, these are the options that they can take. And so here's Harvoni. And in Harvoni, if you have less than a 6 million viral load, which in Hep C is low, you know, obviously in HIV we would be like, oh my God, but in Hep C that's really low. You only got to do 8 weeks. And the cure rates in the clinical trials were 97%. And I should note, since I probably should write this down for going forward, but clinical trial rates are always higher than the rates when they get out into the real world. You know, in clinical trials, folks tend to be relatively healthy. You know, they won't have as much cirrhosis in this particular case, for example. They're motivated, they take the meds, you know, they might even have more adherence counseling going on than you or I would get in our regular visits with a medical provider. And it used to be that folks would say, you know, once the drug gets out into the community writ large, you could probably subtract up to 20% from SVR rates. So 97% in theory might be 77%. But one of the really neat things that's going on in hepatitis C is the CDC is studying real-world SVR rates. They have a research study going that the name of which has just completely slipped my mind. Wow. Anyway, and what they're finding is the cure rates in the community very closely mirror cure rates in these clinical trials. And that's the power of these drugs. I mean, these drugs are really, really strong, and they're very forgiving. And so if folks take them, they tend to get cured. So when we look at these clinical trial rates, it might not be 97% in the community, but it might be 90. You know, it's really close. And so it's still worth reviewing these. All right, that was a much longer explanation than it needed to be. If you got a viral load greater than 6 million, you do need to take Harvoni for 12 weeks. But again, the cure rates are quite good. And then you've got Vicarapac. It's a little, the cure rates are a little bit different dependent upon the subtype of the genotypes. The subtype doesn't really matter when it comes to Harvoni. For the record, genotype 1B responds to drug treatment a little bit better than genotype 1A. And then that last one there, Sovaldi and Alisio, is another option. I would guess it would be less likely to be used than the other ones, but it's still something that folks have on their plate. Next slide. So now it gets a little bit different. You've got a treatment-naive person who has cirrhosis. What should they take? And then here are your options. As you can see, the differences are minimal between Harvoni and Vicarapac. And I actually should note with Vicarapac, you do have to take Ribavirin here. The main difference between Harvoni and Vicarapac is Harvoni is 1 pill once per day. Vicarapac you have to take twice per day. And so adherence might be a little bit more challenging. AbbVie, which makes Vicarapac, they did a really nice job of putting it in a little blister pack, so it's pretty easy to manage and remember. But if adherence is an issue for somebody, a once daily regimen is always preferred, and so there's Harvoni. Next slide. So here's somebody who's tried treatment before, it didn't work. Their liver is in good shape. What should they take? And then these are the options there. Again, Vicarapac in this particular case should be taken with Ribavirin. Next slide. So here's treatment was unsuccessful in the past. They've got cirrhosis. What should they take? So there you can see some differences. 24 weeks of Harvoni, it's 100% cure rates in the clinical trial. Vicarapac, all of these you have to take with Ribavirin. And you see the cure rates and the durations. If you take it for a little bit longer, you get some better outcomes. Next slide. Genotype 2, this is pretty much what you take. Sovaldi and Ribavirin. And the cure rates, as you can see, are quite good, even with cirrhosis. Next slide. Genotype 3. Genotype 3 was, I said genotype 1 was the hard to treat. Now it's genotype 3. Genotype 3, you got to take longer, 24 weeks. If you're treatment naive, the results have been pretty good. If you're treatment experienced, especially treatment experienced with cirrhosis, it's still not as successful as we would like to see. That's kind of the new horizon for treatment, is how can we improve the treatment rates for people with genotype 3. Next slide. And then 4, Sovaldi and Ribavirin. Europe actually approved Vicarapac for genotype 4. For whatever reason, the United States, the FDA did not. So I suppose a person could do Vicarapac off-label, but right now, in terms of FDA approval, this is what somebody's got. Next slide. And then if somebody's living with HIV co-infection, the nice thing is these regimens can all be taken for people who are co-infected. And the rates of cure are pretty close to folks who just have hepatitis C. So it's really kind of neat that we have this available to them. Prior to all of these new drugs, the only FDA regimen that was approved for co-infection was Ribavirin and Interferon. Those first-generation protease inhibitors I mentioned previously, they could be used off-label for co-infected, but they weren't FDA approved. And there was like drug-to-drug interactions and a lot of issues. And so, and then the other nice thing is interferon kind of chews up your CD4 cells. And so folks who would start that regimen, their T cells might drop a little bit. They come back, but still it's something that is quite nerve-wracking. That's not an issue here. CD4 count stays the same when folks are on these new meds. Next slide. So the next couple of slides, and then we can move into conversation for the last 10 minutes, are what to look for at CROI and some key issues in hepatitis C. So you'll probably see studies that are looking at treatment duration. The goal is to get shorter and shorter. 8 weeks is what we've seen thus far. That's the shortest that we can go. 6 weeks is probable for some of these drugs. They're looking at it now, and then in some of the drugs in the pipeline, 6 weeks is definitely a goal. It's unlikely they'll go lower than that. Merck tried a 4-week thing. It didn't work, but you never know. So it'll be interesting to see treatment duration. And then studies that are looking at treatment outcomes for genotype 3. That's our new hard-to-treat genotype. That's a piece that folks are going to want to look at. It's the next slide, the previous slide, sorry. You'll see lots of stuff on HIV and Hep C co-infection, I'm sure. And then maybe, I hope, I'm not sure if at CROI, but definitely at EASL and AASLD, the middle and end of this year, the benefits of cure. There's a really emerging field of research here that are looking at what's called patient-related outcomes that show the benefits of curing people from, relieving fatigue, improving mental fog, all sorts of things that have been traditionally dismissed when patients have argued, God, I feel like crap. Oh, it's not the hepatitis C, it's something else. But we're finding when you get rid of that virus, everything gets better for a person. It's really remarkable. And this research is really, really important because as advocates, we can use it to argue for the reasons for treatment. Right now, if you've got a pretty healthy liver and you're on Medicaid, you're not going to get treatment. Medicaid's not going to pay for it because their argument is your liver's fine, and they're only prioritizing people who have sicker, more cirrhotic livers. But if we can say, you know what, you get rid of this virus, and then this person feels better, they're going to utilize fewer health resources, they're going to get back into the job market, all the quality of life things that we talk about, we can make stronger arguments for curing people now. So there's likely to be some things there. Next slide. And then if for those of you who are going to the conference, who maybe have never been to a conference before, it's really intimidating. They're fast and furious. Folks are up there for 10 minutes, and they're just blasting through slides at a really fast rate. There's no possible way you could take notes on all the things you need to do. You can use your smartphone or tablet to take pictures of important slides. Even if they say you can't do it, everybody does it. So, if you see other people taking pictures, do it. Take a picture of the slide. Focus on the summary slides. And then, I don't know about how you guys are, but I can be really intimidated by some of these researchers. And, I read their stuff, and I'm like, oh, you're so smart, you're this, you're that. They're really quite nice. And if there's something that's particularly interesting to you, or even if you want to get a copy of their slides, don't hesitate to walk up to somebody, after a talk, if they're not surrounded for people, or during the breaks when you're getting coffee, you're going to run into people in the hallways. And then the next slide is a real easy way to kind of keep up with the news, not just here, but anywhere. for HIV and hepatitis C. So NATAP, which is run by Jules Levin, you know, the great thing about this site is they will post the slides from conferences, and they get them up fast, sometimes the same day. And so, you know, you don't have to worry about taking all these notes from this presentation because you're going to be able to reference the slides on NATAP and take a look at them. And he updates them pretty regularly. So even after the conference, keep looking at it because stuff will come up. So that's a great place for the original material. And if you're interested in sort of a summary of things that are prevented, in my opinion, and this is my bias, HIVandhepatitis.com is just the best. It's run by Liz Heileman, and she has some other health journalists. And the way that they write is just super direct, super clear. They bullet out key points, so it's almost like a Cliff Notes version of the presentation. And I just find it a real valuable way to put things out there. I write stuff too, and I will be writing about CROI. I'm not going, unfortunately. My travel budget doesn't allow me, but I'm going to follow through NATAP to look at the original slides. Sometimes CROI has webcasts and things like that, so I'll be able to watch some presentations that way. And that's really it. The next slide is just a drug guide that I write every year. 2015 will be coming out in July, and I'll have all this drug information in intimate detail. This is the version from last year, and then you can always come to the Project Inform website and keep your eyes open for hepatitis C news. And anyway, so that's that. Sorry if it was a bit of a rush towards the end. I hope it wasn't too nutty, but we have 5 minutes for questions.
So I did get one question in about the slides. I'm going to email them right after the webinar ends. But if anybody has any other questions, I'm going to check to see if anyone has their hands up to see if there's any questions on the line. And then I'll go ahead and unmute everyone so that you can just kind of speak freely. So are there any questions for Andrew? And of course, you can send them in the chat box, you can send them in the question box, or you should be able to speak now.
Yeah, I was going to say, can you hear me?
Yes.
Oh, excellent. So thank you. This is Deirdre from AVAC. Thank you so much. A real pleasure to learn more about an issue that we don't, at least on the AVAC side, do a whole lot of work on. But I don't think I realized sort of the stat that you had from one of your earlier slides about the percentage of people who naturally clear it. And as you said, you know, we don't understand the mechanism of action for that because obviously we would target that kind of thing. Is there any research there, or just sort of thinking on the prevention side? Obviously, you know, there's a lot of harm reduction that we can do to help on the prevention side, but just to think, like, is there any basic research ongoing looking into that?
Yeah, and there is some stuff, like it's come out of Australia. Jason Grebely is one of the authors, and there might actually be a little bit of a protective factor that these folks have, but it's not anything that they've been able to sort of definitively say that would be meaningful for our clients. And then there is some vaccine research going on as well for hepatitis C. To date, it's been a very elusive virus to a vaccine, the multiple genotypes, the subtypes, but there has been some research, and there's actually one going on here in San Francisco that's looking at the effectiveness of a vaccine in young injection drug users.
Oh, wow. Thank you.
Awesome. Are there any more questions from folks? Okay.
I either was so good that I answered everybody's questions, or I was so bad nobody wants to bother with me.
I'm going to go with the first one. I feel like every time, this is my second webinar with Andrew now, and I feel like I learn so much more every time. So we really do appreciate you
It's always
joining us again.
no problem. It's also such a fast-moving topic. Like, it's hard to keep up, and so yeah, every time I present, there is something new to do, which is pretty cool.
Yes, it's really a pleasure working with you.
Nice.
So I will send out all of this information along with Andrew's email, so in case you do have questions that come up within the next couple of weeks before CROI, you can shoot him an email. He's very accommodating in that regard. And I'll send out the slides and the recording as well.